Hi, good day dear colleagues, this is Dr. Jihad and our today's lecture is a continuation to the series that we have started, What Surgeons Should Know, and today we are going to talk about the anorectal physiology or the function of the rectum and anus. And as you remember from the previous lecture when we talked about the colonic physiology or the function of the colon, we defined the colon from the cecum up to the sigmoid, and we said that the colon participate in absorption of water, absorption and secretion of certain electrolyte. It also participate in moving the colonic content toward the rectum, where the contents accumulate, or the feces accumulate before defecation. So when we start to talk about the anorectal physiology, this will indirectly lead us to talk about the two main complex mechanism, the defecation and the continence, and these are the main function of the anorectal region. And actually understanding these two complex mechanisms require good understanding of the nerve supply to this region, how voluntary and involuntary reflexes control this region, a good understanding of the anatomy of the anal canal, including the sphincters, anatomy of the pelvic floor, because all of these will participate in our understanding of the defecation and continence mechanism. For example, pelvic floor, including the puborectalis, it participates in the defecation process. Also, we will notice in this lecture that there is an association between the urogynecological pathology and the anorectal pathology, and this is logic because they share the same embryological sources. Okay. The anatomy that will help us in understanding the physiology of the anorectal region, we have to understand that the rectum, actually it's about 12 to 15 centimeter long, and it starts from where the haustration disappear, lack of haustration, tenii and epiplochii. We start to talk that here ends the sigmoid and starts the rectum, and the distal end of the rectum is where the rectum travel through the levators, especially the puborectalis. We have what we call it engulf actually the rectum and causing the anorectal junction. We can even palpate it by digital rectal exam. This is the distal end of the rectum. What else in the rectum we have? We have the valve. We call it the valve of Houston. We have three valves: upper, middle, and inferior valve, superior, middle, and inferior valve. Actually, they have no clear function. Some theories say that they participate in the continence mechanism. The most constant is the middle rectal valve. Superior and inferior can be absent. Middle rectal valve correlate with the anterior peritoneal reflection. Okay. We said if we move a little bit down, we start to talk about the anorectal ring. We said it is the place where the puborectalis engulf the rectum and where the rectum goes through the pelvic floor muscle. Here starts the surgical anal canal, which is longer than the anatomical anal canal. Surgical or functional anal canal starts from the anorectal ring up to the anal verge. It's about 2.5 to 5 centimeter, shorter in female. The mean in female is 4 centimeter. So this is the surgical anal canal. We have the anatomical anal canal. The anatomical anal canal starts from the dentate line. We said that we have a transition zone from the columnar epithelium to squamous epithelium. There are many differences above dentate and below dentate. We will review them, but here starts the anatomical anal canal from the dentate line up to the anal verge. If we are going more distal from the anal verge, if you remember, we talk about the perianal region. Perianal region from the anal verge, 5 centimeter radially. Okay, what else we want to add regarding the anatomy? Okay, the rectum contains smooth and longitudinal, circular and longitudinal smooth muscle, 3 valves. Okay, okay. We said that the dentate line, actually we have 1 to 2 centimeter, we call it the transition zone. It is where the embryological or the, we define it as the anatomical anal canal starts. And actually we have a zone called the transition zone. It's 1 to 2 centimeter. It wears the, above it we have columnar epithelium, below it we have squamous epithelium, even the nerve supply above and below this transition zone. We talked about in details about this transition zone, and we said that it may be the precursor or the source of the carcinogenic cell in anal cancer. Okay, what else we do not say? The anatomy of the external anal sphincter, of the sphincter muscle, as you see here. We have actually 3 sphincters that make the anal canal. First is the internal anal sphincter. This one is the internal anal sphincter. Okay, internal anal sphincter. The internal anal sphincter actually is a continuation of the circular muscle of the rectum, so it's hard a little bit to define its proximal or upper border because it's continuation with the circular muscle of the rectum. It is innervated, involuntary, under autonomic innervation, sympathetic and parasympathetic, and it's usually in a state of tonic contraction. Okay, between the internal and external we have what we call it the conjoint longitudinal sphincter or muscle. The conjoint longitudinal muscle, again, its function is not clear, but they said that it's actually support in the continence mechanism. The most external we have the external anal sphincter. Actually it have 3 parts. As you see, we have, it's not mentioned the 3 parts of the external. It's the deep, superficial and cutaneous part. This is the external anal sphincter, and you can see that it continues up with the puborectalis muscle, and it is more distal than the internal anal sphincter. This is the internal anal sphincter, and it is under somatic innervation. The pudendal nerve here take the role of innervation. It is also under a state of tonic contraction, which prevent defecation. And you can see here the slit here is the intersphincteric group. Here, from here, you who perform surgeries, for example, for fissure and do sphincterotomy, you can feel the sphincter here between the 2 sphincter. Okay. What else we want to add regarding the anatomy before going to the elevator? We said that the internal anal sphincter, its thickness is of 2 to 3 millimeter. It's thick. We said that it's a continuation with the smooth muscle of the rectum. Okay, the conjoint longitudinal muscle and the external anal sphincter, which is a continuation of the puborectalis muscle Okay, the pelvic floor muscle, we have actually three pelvic floor muscle. Let's see them here. These are the pelvic floor muscle. Actually, this is the hand technique to remember the pelvic floor muscle. You can imagine this is the rectum, and around the rectum we have the puborectalis, we have the pubococcygeus, and the iliococcygeus. What interests us is the puborectalis. Actually, it engulf. I think we have a picture. It engulf. We will see when we talk about it. Engulf the rectum, and we said at this region we have the anorectal junction. It can be palpated by hand. We can feel it by digital rectal exam. Tenderness may be there, and this is a clue for the pain there called chronic anal pain, idiopathic chronic anal pain. Actually, this is due to the inflammation of the puborectalis muscle. So we have three pelvic muscle, as we said. This is, you can see the levator ani muscle or the pelvic floor muscle. These are the pubococcygeus, puborectalis. This is the puborectalis. Okay, and iliococcygeus. Do we have other pelvic floor muscle? Yes, we have the perineal muscle, the transverse, I think superficial transverse perineal muscle, but we are talking about the anatomy that will help us in understanding the physiology of the anorectal physiology. Here, the levator ani muscle divided to three muscle: pubococcygeus, puborectalis, U shape. Here we have the anorectal junction or the anorectal ring. It's palpable on digital rectal exam, and the iliococcygeus. Let's go a little bit back. I think here is a nice picture showing you that the differences between the above the dentate line and below the dentate line. Sorry for that. Okay, we said this is the transition zone, the dentate line. You can see that above it we have different lymphatic supply. Above the dentate we have the lymphatic drainage to the internal iliac. Below the dentate to the superficial inguinal epithelium. Above the dentate it is columnar. Below it is squamous epithelium. Embryogenically, above the dentate line from the endoderm, below the dentate line from the ectoderm. Arterial supply above the dentate line to the superior rectal, which goes to the inferior mesenteric, and then to the portal circulation, and below the dentate it goes to the iliac artery, to the systemic circulation, vein supply, hemorrhoidal nerves above the dentate line. Actually, it is sympathetic and parasympathetic from the inferior hypogastric plexuses. Parasympathetic, it is, we call it the pelvic plexuses or nervi irrigans. We will talk about it. It originates from S2 to S4. So briefly, above dentate line sympathetic and parasympathetic, below dentate line it's somatic through the pudendal nerve. Okay, the innervation of the rectum and anus, it's better to review them like this: rectum and proximal anal canal and distal anal canal. And when we start to talk about the distal anal canal, we have to imagine the external anal sphincter, and we said that the external anal sphincter goes beyond the internal anal sphincter. Actually, when we talk about the colonic innervation, we said we have autonomic innervation, we have no somatic innervation. In the colon we have autonomic in a form of parasympathetic and sympathetic. This depends, this actually will be by the hypogastric plexus, superior and inferior hypogastric plexus. When we go a little bit down to the rectum and upper anal canal, it is the same principle. It is autonomic, it is involuntary, it is parasympathetic, uh, and sympathetic. If we are talking about the sympathetic, it is from the L1, L2, L3, L4, L5. For example, the parasympathetic innervation, the sympathetic innervation to the internal anal sphincter is from L5, while the parasympathetic innervation from S2 to S4, and they are called actually nervy irrigants. Here are they. These are the parasympathetic innervation to the rectum and the proximal anal canal. The parasympathetic and sympathetic innervation to the rectum and the proximal anal canal join together to form the pelvic plexuses. Okay, if we move a little bit down, we start to talk about the external anal sphincter, or the distal anal canal. We said that the external anal sphincter goes beyond the internal anal sphincter. We start to talk the somatic innervation, or the pudendal nerve innervation, and this is from S2 to S4, innervation to the external anal sphincter, external anal canal. It is under voluntary control. It's nice to mention that in the rectum, distal rectum, and the proximal anal canal, we have the we call them the organized sensory nerve ending. These are similar to that present in the skin. These organ that transmit the information to the autonomic nervous system. For example, we have the Meissner corpuscle for touch, Krause for temperature, Golgi for pressure, genital corpuscle friction. These are present in the rectum and the proximal anal canal. Innervation to the pelvic floor muscle, or the levator ani muscle, or the puborectalis muscle, and there also somatic innervation, voluntary innervation, the pudendal nerve. Actually, unilateral injury to the pudendal nerve doesn't cause significant sequences because we have a crossover. What else we want to add regarding the innervation? We said that in the upper and proximal anal canal, including the internal anal sphincter, we have sympathetic innervation from L1, L2, L3, and L5 for internal anal sphincter. We have the parasympathetic fiber, we call them the nervi irrigantes, from S2, S4. They form the pelvic plexus, while in the distal anal canal, or in another word, the external anal sphincter, we have the pudendal nerve, which have two branches, inferior rectal and perineal, S2, S3, S4. And I remember when I was preparing for MRCS, that there is a mnemonic for that. S2, S3, S4 keep the poo of the floor. That means that it participates in the continence mechanism. It is under voluntary. Somatic means voluntary, means pudendal nerve, means external anal sphincter and levator ani muscle. This is the pudendal nerve. We see this is S2, S3. This is the pudendal nerve, give inferior rectal branch. This is the pudendal canal, or Alcock canal, I think they are called. We have also the dorsal nerve of the penis. This is regarding the innervation of the rectum and the anal canal. Let's talk about the normal continence. Okay, in the background of the previously discussed topic, how can fecal continence be explained? How we can preserve stool in the rectum without passive evacuation, without defecation in socially unaccepted occasion. So actually, to understand continence, it is a matter of four mechanisms. First of all, the unique capability of the rectum to accommodate and what we call it the compliance of the rectum, the rectal sensation and compliance. We will explain it. Also, we have some reflexes that will help us in maintaining stool in the rectum without passing it, called the anorectal reflexes. We will explain them. Also, we have the function of the external, internal anal sphincter and the puborectalis and pelvic floor muscle. First of all, to make it simple, this is the normal continence mechanism. It's actually clear that there is no DNA relationship between me and Leonardo da Vinci, but actually, the normal continence, you can see that rectal sensation participate in the normal continence, anorectal reflexes, external, internal, and puborectalis and pelvic floor muscle. What do we mean by that? Simply, first of all, rectal sensation. We know that distension in the colon can evoke pain, while the rectum is capable to distend and to accommodate without pain. And this is a unique feature of the rectum. It can distend up to huge diameter. So this will enhance its capability for storage and will prevent incontinence and will enhance the continent mechanism. One. Two, there is a differences between the intraanal pressure and intrarectal pressure. Intrarectal pressure is low when we compare it to the intraanal pressure. Intraanal pressure is 10 to 15 times higher than the intrarectal pressure, which is about 5 Hgml, 5 mmHg. So this differences in high pressure will actually push the stool up and will help in maintenance. Actually, the accommodation of the rectum to enlarge is a unique feature and only in the rectum, and this is the responsibility of this accommodation is related to what we call it the rectal intraganglionic laminar ending. These actually are mechanoreceptor that are slowly adapting mechanoreceptor that when the pressure increase in the rectum, when the feces accumulate in the rectum, it will slowly adapt, the tone will decrease and the rectum will enlarge. You will understand my words if you are working in a colorectal clinic or see some rectal surgeries that in which the patient does not go to bathroom and actually the rectum is accommodated to a huge diameter with no pain actually. Okay, what I want to say also that defecation, the feel that you want to go to the bathroom, is not a matter of actually, it is sensed at the anorectal, the rectoanal junction where the puborectalis engulf the rectum, the end of the rectum, the beginning of the anal canal. Here we feel the defecation, and this may explain why the defecation process may be normal, preserved in a patient who after proctectomy. We remove the rectum, but the defecation process is normal because the sense of defecation is at the last part of the rectum and the beginning of the anal canal. Okay, this is one. the anorectal reflexes, how do they participate in the continence mechanism? How do they prevent spillage of stool? The most important reflex we know and we have is what we call it the rare reflex or recto-anal inhibitory reflex. What happens actually when the rectum is full of stool and distended? It sends a signal to the proximal anal canal, so that when we say the proximal anal canal, it's in another word the internal anal sphincter. When we say external anal canal, it's another word the distal anal canal is the external anal sphincter. So when the rectum is distended, it sends inhibitory signals to the internal anal sphincter, which is in a state of tonic contraction, to relax. So stool can pass from rectum to anus to the proximal anal canal, and this will allow for special sensory receptors to feel that there is significant amount of stool in the rectum. What the reflexes will do: contraction of the external anal sphincter, contraction of the pelvic floor muscle. This is one. Also, pair reflex will allow us to pass gases without passing stool, because actually the external is contracted, internal is relaxed. Rare reflex or recto-anal inhibitory reflex happens every 6 to 8 minutes for less than 10 seconds. It's absent in Hirschsprung disease, and it is poor function in patients who undergo proctectomy. Okay, we have other reflexes that participate in the continence mechanism, but in a lesser degree. These are, for example, the here are they, I think, the cutaneous anal sphincter reflexes. Actually, touch or pain to the anal skin will cause, all of these reflexes will cause contraction to the external anal sphincter and maintain normal continence. The cutaneous anal reflexes touch to the anal and perianal region. Pulpocavernous reflexes, actually touching or squeezing the glands of penis and clitoris, will also cause contraction to the external anal sphincter. And the cuff anal reflexes, an increase in the intra-abdominal pressure, coughing, laughing, sniffing, actually will cause contraction of the external anal sphincter. What else we want to add regarding okay, let's move a little bit about the function of internal and external anal sphincter. We said that the anal tone is a responsibility of the internal anal sphincter. Actually, the internal anal sphincter, which is under some sympathetic and parasympathetic innervation, involuntary, is usually contracted, and the pressure in the anus is the responsibility of the internal anal sphincter, up to 70%. So this is one. And actually, any injury to the internal anal sphincter will lead to passive stool incontinence. You will not feel that already there is soiling, stool in the underwear. Okay, this is regarding the internal anal sphincter, which participate in the majority of the anal tone and the anal pressure, up to 70%. The hemorrhoids participate in about 15% of the anal tone. So we have rule of the hemorrhoid. Physiologically, they participate in the continence. Internal anal sphincter participate, which is normally at a state of tonic contraction. The external anal sphincter, yes, it participates in the tone, but in a lesser degree. The importance of external anal sphincter that it is voluntary, voluntary, and we will talk about it when we start to talk about the defecation. But now we are talking about the continence. It is voluntary, so we can contract the anal, the external anal sphincter until the situation is socially acceptable for defecation. We said that the external anal sphincter under somatic innervation and actually or autonomic innervation to the external anal sphincter is the vice versa of the other part of the colon. For example, we said that sympathetic innervation is inhibitory to the internal anal sphincter and other part of the GI. They actually excitatory to the external anal sphincter. In another word, sympathetic innervation, which will decrease the contraction of the colon and rectum, it will increase the tone. And when we want to defecate, for example, parasympathetic will increase the motion. It is excitatory to the colon and rectum, but it will inhibit, relax the external anal sphincter. Any injury to the external anal sphincter will cause not passive stool, but urge fecal incontinence. Okay, puborectalis muscle, how does it participate in the continence? Actually, the puborectalis engulf the rectum. It causes this angle. The angle is about 100, and actually it pushes the puborectalis pushes the rectum to the pelvic bone, so it prevents the incontinence. What else we didn't add regarding this? Okay, sometimes the puborectalis muscle, they call it the deep anal sphincter or flap valve theory. What else we want to add? We say, as we said, the anorectal junction, it's about 90 to 100 degree at rest. It widened, relaxing the puborectalis, widen the angle and make it more straight for defecation. So this is how continence occurs. Rectal sensation compliance, reflexes including the rectoanal inhibitory reflexes, function of internal external anal sphincter, and function of the puborectalis muscle. What else we want to add regarding the continence mechanism? The external anal sphincter fatigability is more than the internal anal sphincter. Okay, I hope you understand how does puborectalis participate in the continence. I think we have a picture here. This is the puborectalis muscle. It actually pushes in cases of continence. It is contracted, it pushes the rectum towards the pelvic bone, and it actually the angle is about 100 to 90 to 110. With relaxation, the defecation happens and the angle will increase. Okay, this is regarding how do we keep stool from in our rectum. Okay, this is the mechanism of continence. Let's move to the normal defecation. How do we defecate? Okay, we said in the previous topic that with normal continence, the stool reach up to the proximal anal canal with the help of the rear reflex or rectoanal inhibitory reflex, which is responsible for relaxation of the internal anal sphincter. So stool can start to reach the proximal anal canal, but it contracts the external anal sphincter. At this level, we have what we call it the conscious suppression. Is it socially acceptable to go to bathroom or not? And this voluntary control will either contract or relax the external anal sphincter and the pelvic muscle. If it is socially acceptable, so relaxation of the external anal sphincter, relaxation of the puborectalis muscle, straightening of the angle with the help of squatting, with the help of the increase of the intra-abdominal pressure, defecation will happen. Before that, the defecation also is influenced by the colonic motility, the mass motility we call it. When we start about to talk about the colonic motility, we said we have peristalsis. So rectal distension can evoke or stimulate the, we call it the long axis reflexes, can stimulate the colonic motility, the mass motility, so the stool is pushed toward the rectum to increase the pressure to push it out of the anus. Okay, we said the borderline between continence and defecation is the conscious suppression. Okay, this is a nice picture. Actually, let's before the picture, let's say we said that colonic movement will push the stool or the content toward the rectum. Rectal distension, the rectal distension will stimulate the colonic movement, the mass movement. The gastrocolic reflexes will be stimulated, the mass movement and the movement of the stool toward the rectum, and also will stimulate the rear reflex. The rear reflex will relax the proximal anal canal, will contract the external anal sphincter. The stool will reach to the level of the distal anal canal. At this level, we have the conscious, as we said, the conscious suppression, which is the responsibility of the external anal sphincter. If it is acceptable, you want to defecate, so the puborectalis muscle will relax, straightening of the anorectal angle. Here is a rule that the conjoint longitudinal muscle contract. This will actually shorten the anal canal. When we talk about the conjoint longitudinal muscle, we said that its role is unclear, but it may participate in the continence and the defecation mechanism. Here they say that when the conjoint longitudinal muscle contract, it will shorten the anal canal, so will facilitate defecation. Pelvic floor muscle will descend, sphincters will relax, internal and external, rectosigmoid contraction, squatting will help, and the last thing after defecation, after opening of the anus and the stool comes out, the anus will close. This is called the closing reflex. Here we have a nice picture discussing the defecation process. Starts with distension of the rectum. Then there is stimulation of the stretch receptors. This stimulation will affect short reflexes and long reflexes. Actually, short reflexes, these are the, for example, the rectoanal inhibitor reflex. The long reflexes, these are the gastrocolic reflex, which will enhance the mass movement of the colon. So peristalsis is increased before defecation. What else? Finally, there is a relaxation of the internal anal sphincter and contraction of the anal internal anal sphincter if it is accepted to defecate. So relaxation of the external anal sphincter under voluntary control. Okay, this is regarding the defecation. Okay, how to test the previously mentioned function of the anorectal region. We have physiological testing. Actually, these physiological testing, for example, the anal manometry, pudendal nerve terminal motor latency, balloon insufflation, defecography. Actually, this topic will be discussed separately in another lecture called the common test for pelvic floor. It's actually beyond the interest of general surgeon, but as I always says that there is no clear border between general surgery and colorectal surgery. So if you are interested, you are invited to watch this lecture. And of course, fecal incontinence, we talked about the normal continence. Fecal incontinence, we will have a separate lecture talking about the fecal incontinence and how to evaluate and to treat. Okay, an entity of anorectal pain or idiopathic anorectal pain, it's actually, you can elect it, for example, in the absence of any organic cause or anatomic cause, when there is no trauma, no fissure, no bile, and there is anorectal pain. It can be explained as idiopathic pain, which is called chronic proctalgia if it is more than 20 minutes, or proctalgia fugax if it is less than 20 minutes. It's a kind of severe intense pain that is transient, and it may be idiopathic, associated with psychological disturbances, or sometimes it may be explained by inflammation of the puborectalis muscle. It can be elected during digital rectal exam. There will be tenderness at the anorectal junction. Urogynecological consideration with functional defecatory disorder with a problem in the anorectal region, such as fecal incontinence, obstructed defecation, rectal prolapse, rectocele, sigmoidocele, anorectal pain. They are frequently coexist with other urogynecological conditions such as urinary incontinence, retention, uterine prolapse, chronic pelvic pain, and this is maybe explained because they share the same, as we said, they share a common embryological origin. They share the same muscles of the pelvic floor. They share also, there is overlap in the innervation. So this may explain that. We reach the end of our lecture. Thank you. Bye bye.